as you can see, we've had many meetings and put a lot of thought and read hundreds and hundreds and thousands of pages on healthcare reform. And we've come to the conclusion at our board, and by the way, I'd be remiss if I didn't introduce Dr. Larry DeGroat, who's sitting up here. Go ahead and stand up, Larry. Larry is the chairman of the board of MDA Insurance and Financial Group. He's been doing that for 6 years, and he's also been the chairman of the insurance committee. I told you I had my 19th anniversary here, and Larry's been the chairman of the insurance committee that whole time. So here's a guy who closes down his practice, takes his time off, and comes and works hard on all of your behalf to be able to offer a good health insurance program to members. We have 10 other like individuals like himself on the board, 4 or 5 on the committee, but definitely stop and say hi to Larry and thank him for his efforts as you leave today. So having said that, though, our board and our committee and us as staff have been very concerned, obviously, with what we're seeing here. We're seeing higher costs for worse coverage if we just go along with the flow here, all right? So we hired some outside consultants, a firm called Levitt Partners. Michael Levitt, the head of that, is a former governor of Utah. But more importantly for us, he's also the former head of Health and Human Services, HHS. Health and Human Services is the federal entity that's in charge of implementing healthcare reform. And so this gentleman is not the current head of HHS, but because he was the former head of it, of course, still knows a lot of the staff people there and is able to get some inside scoop for us on what may or may not work as we go forward in the future. So we've been working with Levitt Partners, and we came up with the concept of what's called self-insurance. Self-insurance, and in this case it's called a MIWA, a multiple employer welfare arrangement. So self-insurance, think General Motors or Ford or Chrysler, okay? Their employees, they have a Blue Cross card still, or an option to have a Blue Cross card, but so they can still go to all the same hospitals and physicians that an insured person with the Blue Cross card can. But when it actually comes time to pay the claims, who's on the line to pay the claims is not Blue Cross, it's GM, Ford, or Chrysler, okay? So GM, Ford, or Chrysler rents, if you will, or pays a fee to have access to Blue Cross's network, and then they take the risk on themselves that we think we're going to pay less by paying these claims ourselves than if we let Blue Cross pay the claims, okay? Now, when you do that, there's a thing called reinsurance, which is essentially insurance for insurance, so that you cap your losses. So you don't just, let the plan pay, up to $5 million or unlimited. You have a cap on that. Actually, we have, this is, interestingly enough, even though we have an insured plan with Blue Cross, we operate it very much already right now like a self-insured plan. So we have an annual sit-down with Blue Cross, and there's an amount of dollars that we collected in premiums, and then there's an amount of dollars we paid out in claims and administrative expenses. And some years that number comes out where we paid in more and there's a positive balance. In some years, we paid more in claims than we took in premiums, and so there's a negative balance. So right now, when there's a negative balance, that's Blue Cross's problem, all right? So we went negative $1 million last year. Blue Cross's problem, okay? In a self-insured world, the problem of plus or minuses become the self-insured entities. Now, as a dental practice, nobody would want to take on the self-insured risk on their own, okay? A practice of 5 or 10, you have one person in the hospital, where are you going to get the money, from to self-insure and pay a hospital bill? But together, all the mighty bunch of us, we have the capacity to have a self-insured plan. And so some of the benefits of a self-insured plan is, number one, we don't have to comply with the essential benefits. So if we decide we don't want to have pediatric dental, for instance, on our policy, we don't have to. Some of the metal tiers and premium rating rules, we don't have to be at the 80 or 90%. We could have an 85 or 92 if we want to. Most importantly, probably from our perspective, we don't have to aggregate the risk pool. So we're back to just MDA members and staff. We're not getting stuck with all the uninsured, all the high-risk occupations, all that kind of stuff. And we avoid some of the taxes. The big tax you saw on the other slide, the 2.5% to 3.5%, it's a tax on insurance companies, okay? So this is an insured plan, so we avoid that 2.5% or 3.5% tax. So we think there's a lot of good reasons to consider the self-insured MIWA concept. So instead of one large employer like GM or Ford or Chrysler, what we really are is a group of small employers. And the law of the state of Michigan and the federal government allows for multiple small businesses to aggregate together and form a self-insured MIWA as long as they had some sort of a pre-existing mutual relationship that wasn't just to buy insurance. And of course, what we have is the pre-existing mutual relationship that you're all members of the Michigan Dental Association or staff people of members of it. And we didn't create the Michigan Dental Association 156 years ago, if you read the plaque out there, because we wanted to be able to form a MIWA when Obamacare came around, right? So we're good there. So we meet the criteria that we had a pre-existing relationship with each other that allows us to group together and consider this self-funded idea. We would be able then to customize our own plan designs just the way we always have, decide what our drug copays are, what are we going to pay benefits on. It'll be controlled by fellow MDA members who are participants in the plan. So they, all would have a vested interest in its success, just like they do right now. We all have participated in the plan, and obviously we want to have the plan succeed. So we think there's a lot of good behind this self-funded concept. We have as we go through the cards here, all right, in the pink card we have 4,000 contracts, probably 10 or 12,000 people there. And our Medicare age people, we've got over 1,000 folks times a spouse, it's close to 2,000 people. In our orange group cards, we have another 1,000 contracts with 3,000 or 4,000 people. So all totaled, we've got 15,000 to 20,000 people already insured here right out of this building that call here and pay the premiums here, and we help with their claims and whatnot. And so if we can just get even a small portion of that interested in it, we have more than enough volume to pull this off. So how it works, it is a little different. So right now our exclusive plan is individual. They're individual policies like we talked about. If you have 5 people in your office insured, you get 5 separate bills. And like we just talked about, you can be in it and your doc doesn't even have to be in it. Or 3 people can be in and 3 out. It's totally each individual's choice. A MIWA does work a little differently in that it has to be a sponsored group by the owner of the practice, which is obviously going to be the dentist in most cases. Now, to sponsor a group doesn't mean you have to pay for anything, all right? Which obviously some of you may elect to pay for it, again, to attract and retain good employees. But sponsoring a group doesn't mean you have to pay for anything. You could say, I'm going to offer, because remember, the affordable thing doesn't apply, right? If you're under 50 or more, you don't have to offer affordable insurance to your employees, or at least you're not threatened with a tax penalty if you don't. So you could have a sponsored plan in your office where you say, I'm going to pay 100% of the employee's premium. You could say, I'm going to pay 50% of the employee's premium. I'm going to say 70%. You could say, I'm going to give everybody $300 to go towards their insurance. Structure it however you want to. That's still your business decision. But the key is that you, as the employer, are sponsoring this plan in your office and you're making it available to all of your staff, okay? How you set up the payment, that's your own decision.
Can you pay zero?
Yeah, so the question there was, could you pay zero? So you could sponsor a plan and you could say, at this point I'm not able to contribute to it, but knowing what's going on these exchanges or marketplaces, we think this might be a more attractive option for you. So you sponsor the plan, and what would probably happen in that scenario if you're paying zero is that those people who are not eligible for a subsidy would probably look at our plan and say, okay, that looks good, we'll go with that. And the people in your office who are eligible for a subsidy, if subsidies ever work and if exchanges ever work, we might take them over and shop with them on the exchange a little bit, okay? So that might be one way to do it. Another way to do it could be, I'm giving everybody $300 a month to buy insurance with, 50% of premium, 75, anywhere. It's your own business. So a lot of your business decisions have been taken away from you, but that's one that hasn't. What you want to contribute to your employees' health insurance. Now, I'm a big advocate of helping them pay a little bit because I do think it helps retain and attract good employees, but individual office circumstances and finances will dictate what you are able and what your competition is doing in your local area. Those things will all probably dictate your own personal decision on what you're contributing. So the key is, though, it's got to be consistent. So amongst the fine print that hasn't been detailed out yet is there was supposed to be some discrimination rules. They were supposed to take effect back in 2011. So they decided back then in 2011 they couldn't get their arms wrapped around exactly what they were trying to do or how to do it. And I still haven't seen them come up with anything. So there is no discrimination rules as we stand here right now, at least that have been published. But you can apply a little bit of common sense to it. So in that scenario, you're perfectly fine. I'm offering everybody 0. You're treating everybody totally even. That's not discrimination. What is discrimination is if you say, hygienist A, I love your work, you've been here 20 years, I'm paying all your premium. Hygienist B, not so much, not paying for your premium, all right? So that's that kind of thing you can kind of rest assured is, when they do publish the rules, is probably not gonna float or fly. So the key is that you're treating everybody equally. Now you might be able, and again the rules aren't published, but you would surmise that you might be able to treat people, even though you're treating people equally, you can still treat them differently by maybe how long they've worked for you, maybe what their occupation is, maybe things like that. So for instance, at the MDA, our percentage of the premium that we pay for a brand new employee is less than once you've been here 5 years. So you come in at 1%, and then once you've been here at 5 years, those people are getting a higher percentage of their premium paid. That's not discrimination. You're treating everybody equally, okay? The people who are here 0 to 5 years get a certain percentage. The people that are 5+ get a certain percentage. Yes? So yeah, if you only give it to your spouse and not to anybody else, that would probably be a problem. But again, I'm just speculating. The actual discrimination rules have not in front of me. Well, if you're a primary insured and she's a person on your policy, now keep in mind, right now you can just buy an individual policy and you and her can be on it, and there's no obligation to insure other people or not or whatnot, okay? And the laws haven't been, nothing's come out to contradict that yet at this point. So, but you got to keep your eyes open for that in the future. Okay? So having said that, it's just important that it be consistent, but it can be consistent, in different ways like we just described. We plan to have all the same kind of plans available we do right now. We're going to have high deductible plans for health savings accounts. We're going to have an assortment of PPO. We'll have prescription drugs. Well, at one of the previous seminars, somebody raised their hand and said, so Craig, it sounds like what you're really trying to do is maintain status quo the best that you can. I said, I owe you $5. That's exactly what we're trying to do. We want to keep our own group together. We want to have our own product designs. We want to have our own rates. We want to avoid some of these taxes to the best of our ability. That's what we're trying to do. So from our standpoint, we'll be designing the plans. Just like right now, we'll be handling enrollment, changes, have a baby, get a new employee, add them. We'll be doing the billing, collecting the premiums, customer service, claims assistance. We do about $50 million of premium with Blue Cross, and that means that about 40 to 45 million in claims are paid every year. That is thousands and thousands and thousands of transactions. And I know sometimes if you might be one of those transactions went wrong, that you might feel like picked upon or something, but periodically when you're doing thousands and thousands of transactions, something does go wrong. It doesn't go quite right. And we have a great team here of advocates for you to help get your claims resolved. Some of you may have utilized that service in the past. We'll still be there for you in this new environment as well. And this last item there, really, unless your name is Craig Start or Dr. DeGroat or maybe Tina, it's really not of concern to you, but we will have a new partner in the venture, okay? So right now, the health insurance program that we offer to you all and the premiums that are charged and everything, it's a negotiation between the MDA and Blue Cross. Those are the two entities involved in deciding what your coverages are going to be and negotiating what the premium's going to be. Well, we're going to have a third partner in on this because a self-funded MEWA requires approval from the state of Michigan. So I don't look at that, like I said, unless your name's Craig Star, Larry DeGroat, it's not an impact on you. I would just say it's probably a good thing. It's just another entity, just like your board, who's already very fiscally responsible, just like Blue Cross, who doesn't want to take a loss. Now we're going to have the state there making sure that we have a financially sound, viable program that's reserved properly. Reserves is a pile of money you have to have on the side in case something bad happens. So we're going to have a new partner in this venture as we do it. But I think that's a good thing. Just another entity who knows what they're doing and keeping us on our toes to make sure we've got all our I's dotted and T's crossed. So from your standpoint, it does work a little different. Like I said, you're sponsoring a group program, which again, we talked about earlier. Right now you're paying a different premium statement on each person who's in your office. This would be one premium statement for the whole office, okay? You got to establish some sort of cost sharing, consistent policy, even if that cost sharing policy is no cost sharing. Providing an employee with an enrollment plan about the information. Obviously, that's critical. A lot of our communication is done between the dentist and us, and we need you to trickle this information down to your staff people. Yes, go ahead. So the question was, is in terms of the employee contributions, would you still want to run a Section 125 plan? A Section 125 plan is a way to have your employees' contribution. So say you're paying 50 and they're paying 50. Their part of it, they would like to pay with dollars that haven't been taxed. So that's the Section 125 plan, and yes, you would still need to have that to have the employees' portion of the premium. So if the employees' portion of the premium is going to be $200, and we make them pay taxes on their money, they might have to earn, $250 or $300 to get $200 in their check, right? But if we run it through a Section 125, $200 in, $200 out, all right? It's tax-free. So that's something you definitely want to do for your employees' share of the premium when you do this. So what are the risks? So, the big risk is, like we just talked about, it's self-insured. So that means we're on the line for the risk, not Blue Cross any longer. But that risk is very seriously mitigated by the fact that we've been doing this. I've been here 19 years. Larry, do you remember when the plan started? Was it probably 6, 7, 8 years before that? So we've been doing this for 30 years. And as I stated earlier, even though it's insured, the plan functions very much like a self-insured plan already. We already have reinsurance, the insurance for the insurance, caps our losses at $300,000 for any one of you. So anybody runs up over $300,000, somebody else has to pay those claims, not us, okay? We already have that in place. We already sit down with Blue Cross every year, and we have a board of directors who's used to doing it. We have outside consultants. We have myself. We always have to sit down with them and negotiate. They say, here's what we paid for you guys last year, and we want to increase rates 10%. And we say, no, it should be 5%. And we haggle and we come to a decision. At the same time, we can't be overly unrealistic about that premium increase. We can't say it should be 0 when, like this year, it needs to be 9.5, because if we take 0, then we're not going to have enough money to pay the claims at the end of the year, right? So that's not a good thing either. So we're running a pseudo self-insured plan already. We just have the safety net of Blue Cross behind us right now. In reality, what happens when you come negative $1 million like we did this year is that's what leads to the years where we have the higher premium increases. And in the years where we come out positive, that's the years like last year where we were able to come in flat, okay? So by proper planning and actuarial statistical analysis, you can come to the right premiums to keep your plan solvent. Other great news for our plan in terms of solvency and financial strength is that this is an evolution of our existing plan. And so the existing plan has accumulated assets in it. You know, the pluses over the years have outweighed the minuses to the tune of in excess of $10 million. Now, $10 million sounds like a lot, but like I mentioned earlier, you know, we do 40, 50 million of premium. But having said that, we have a nice chunk of rate stabilization reserve, which is what the state requires to start a MEWA. We've got that. So someone starting a new MEWA from scratch, we might have to come out and say, just to buy health insurance from us, we need $10,000 from you because we got to build up our reserve status first, okay? So we don't have to do that step. No one's going to have to put $10,000 in just to be able to have the privilege to buy health insurance because we already have our reserves in place coming from our existing plan, okay? So that's a great thing too, and it's a great safety net for risk as well. Okay, so the question is if you go with the MEWA for your office and you get to retirement age and you want to retire, can you stay in the MEWA? We're working on that question. I believe the answer to that is yes, but we don't have it totally locked down yet. Which is a lot of these unanswered questions like that where I might not have the answer. That's one of the reasons why we renewed the plan December 30th, because we just needed extra time to get all this together. All right. So the other risk is that we don't get enough people, all right? So we've been told by Levitt and some of the other consultants that you need, you know, that most successful MEWAs have at least 5,000 bodies or people in them. Like we just talked about, we have 15 to 20,000 bodies or people when you start adding spouses and kids and everything. So there's no reason to think that we can't get the numbers we need to have a successful MEWA. The higher amount of people that we get into the plan, the greater the participation, the more easy it is for the actuaries to make predictions about our future rate needs and everything. Of course, one of the big challenges is this is new. And member education and getting you all interested in adopting this, helping you pay attention to it is a challenge. That's why we're doing this right now. I got another group just this big coming in this afternoon. Going to be in Grand Rapids in a couple weeks. We've been 8 or 10 other places. So we're getting in front of a lot of people and getting this message out. But that's still not everybody. You know, we just said we had 15 to 20,000 people insured. That's probably a couple thousand people I'm in front of. So to the extent that you have staff people that need this information, to the extent that you have colleagues, other dentists who you think might be interested in that, we appreciate your word of mouth that you came here and you're interested in this, and tell your colleague to look out for it as well. Obviously, we're going to continue communicating through the journal, the insurance checkup, our website, and I'm certain we'll have another round of these seminars next year to really tell everyone about what the MEWA really is, and we'll have rates and all that kind of stuff by then. One of our other dilemmas, and this goes to my second question that I held, which was gentlemen really liked the Blue Cross network, hospitals, physicians, and the discounts that we get with them. That helps keeps our out-of-pocket expenses down. So as I mentioned earlier, there's two components to it. There's who's at risk, so in that case that's now going to be the MDA instead of Blue Cross, but there's also who pays the claims and whose network do we use. So our number one priority is we would like that to be Blue Cross. So if that's the case, then the answer to the question is no change, right? So we are in very deep discussions with Blue Cross about having them be the TPA or the administrator of the claims, or that we would continue to use their network. That's our number one goal. We would love that. That way nobody has any disruption on participating providers or hospitals. Our discounts are the same. We think that's what keeps our premiums as low as possible. Now, having said that, as you might imagine, as much as we've been working our butts off here, you know, Blue Cross has been going 100 miles an hour on their end trying to get ready for, they literally in their office on every wall had a clock ticking down, you know, 120 days, 10 hours, 31 minutes till October 1st, okay? So they've had a lot on their plate trying to get ready for these exchanges and all these new products they had to design and get ready. So we just haven't been able to get a solid attention span from them to try something new and different this MIWA venture yet. So they haven't agreed to do it yet, is what I'm saying. We're still pressing them on that, and I think we have probably till early next spring to get them on board with it. If they didn't agree to it, that is not a deal breaker, okay? There's all kinds of networks, reputable companies. We mentioned a few of them earlier, you know, Aetna, United, Priority Health. Those are all big, well-known entities that have networks of hospitals and physicians here in Michigan. And so we have requests for proposals out. We've got 2 finalists, actually, that will be coming in next week to do presentations to us. Very good finalists that we think would be options if Blue Cross doesn't come on board. Again, though, our #1 goal is to get Blue Cross on board with it. As I mentioned earlier, the state's now involved. So once we get this TPA selected, we got to design plans, we got to create rates, and then we got to take it all to the state and show them that we're financially sound, that we have these reserves we talked about. So we got to take that all to the state, and they have to sign off on it. We, again, don't anticipate that that would be a problem because we're well positioned for this, but it's another step or a challenge that we have to face. And then finally, it's the old field of dreams thing here, build it and they will come. So we spend all that time building it. We're not going to really know if you're coming until probably next fall sometime, but we believe very strongly that when you get rid of all these taxes, you get rid of all these mandated benefits, you get rid of all the high-risk people that are going to be in these other pools and keep our own pool together, that we're going to have rates and coverages that are substantially better than what's available on the open market. You know, that's the bet that we're making, if you will, as we plow forward with this venture. We're making that bet for the last 3 months in an information backing. We hadn't even seen the products or the prices on the exchange, remember, till October 1st. Now that we've seen them, Tim, you're back. I was trying to relate your experience. Tim has actually gone and shopped a couple people. So those subscribers who have an individual policy with Blue Cross right now, they were the card color that no one raised their hand in. But those people are all losing their existing policy January 1. So they can't keep what they have any longer effective January 1. And they're just starting to get a sniff of what their new programs look like. And Tim, can you just relate real quickly a couple of the premiums and price comparisons you saw?
Yeah, this was an individual who was 59 years old, and she was looking at options of the marketplace rate. And for the bronze alone, it was about $508. And on the MDA product that we have, she was looking at $353. So I could save her more, even if she was able to receive a subsidy, I could save her more than having her go on the marketplace and doing that shopping.
And so if you could hear Tim, the premium was about $150 to $200 higher for this individual on these marketplace plans than in the MDA plan. In addition, wasn't there a higher copay or deductible exposure as well, Tim? So we have every reason to believe, based now that we're actually seeing rates and coverages, that what we are going to have to answer someone's question earlier, you know, is the rate better at the MDA? We have every reason to believe it will be from what we're seeing right now. And we won't expose you to as high copays and deductibles either, because we're not locked into these metal tiers in this MIWA venture. So how can you help? Number one, you can pay attention. We're going to be spreading the word via many mechanisms. We're going to be doing a survey very shortly in a couple weeks. Give us your feedback. At the December board meeting of the MDA Board of Trustees, they're going to actually take the final vote on is this going to happen or not. And so they're going to be looking for the survey feedback, and they're going to be looking for these MIWA interest forms that you have in your packet in order to help them make that decision. Obviously, then, in addition, how you can help is consider the venture, and you can consider it even if you don't have interest in paying premiums, right? So we already discussed that. Continue to monitor our publications. We're going to have a big article in the MDA Journal that's going to cover a lot of what we just went over here in November. And then throughout next year, you're going to, as the details start to unfold on this, you're going to see more and more of it. Now, I want to wrap up, before we go to the Q&A session here, I want to wrap up one last time and talk to each subset of you individually all the different cards here and make sure everyone one last time knows what's happening to them and when it's happening. Okay? So the first group of people are pink cards, right? You're in our exclusive MDA quarterly build plan. The good news is you get to keep that plan throughout all of 2014, all right? So you don't have to do anything this year other than, like Tina mentioned, if you want to change your plan, you need to do it before December 1st. Once January 1 rolls around, this plan will be locked in through the end of the year. We think that's really good news because it's going to let the dust settle and us to see the premiums and the coverages that are available out on the market. Now, that's the good news. The rest of the story from Paul Harvey is that the end of 2014, that plan will end, unless some big change occurs in Congress, which obviously is being worked on. But if nothing changes, that plan will end at the end of 2014, and you're going to have to migrate to a new plan. So those are your 4 options right below, okay? So we think one of the really good options is going to be our new self-insured MIWA, okay? If for some reason the self-insured MIWA doesn't fit your business practice model, then we can always offer individual products both on or off the exchange. So those of your employees who might be eligible for a subsidy, if the exchange ever works, we would take them out and help them shop there. Those of your employees who are not eligible for a subsidy, we can shop either on or off the exchange for those products. And then the last option for those of you with the pink card would be to become an orange card person, to go to a Blue Cross Blue Shield small group plan. Now the caveat when you do that though is that that's the metal tiers, that's the actuarial values, that's the essential benefits, that's you have to have pharmacy whether you like it or not, whatnot, but it still might be a viable option for some folks, okay? That's in the insured market. The bottom line is on the bottom there. We're here to help you through it. It's going to be confusing. It's going to be different. You're going to need some help. We can get Tim or Averill out to your office. We can talk to you on the phone. We've got access to the web. We're here to help you.